Welcome back to the post-inaugural scientific session. At the outset, I must thank the organizers for arranging such a marvelous academic show, which is an annual event, the mega event, especially Dr. Vitull Gupta. The title for discussion here is a disease which is a silent killer. A disease which has undergone tremendous change in nomenclature, change in the prevalence, change in the imaging and other diagnostic modalities, and changes in the management. Since there are so many changes, so this disease needs a lot of awareness. So we'll discuss about non-alcoholic fatty liver disease. This is turning out to be a new pandemic. It is a common persistent liver ailment now, with a global incidence of around 25%. And 25%, remember, is not a small figure. And it is increasing as a cause of end-stage liver disease and hepatocellular carcinoma. And remember, now it is emerging as one of the leading causes for liver transplantation. Presently it's number 2 on the list. But if it continues going like this, it can take the slot number 1. In short, we can call it the hepatic component of metabolic syndrome. If we have to describe it in very brief, we'll say hepatic component of metabolic syndrome. And it is directly related to diabetes and obesity. Now, as far as our Indian population is concerned, we are much more prone. Why? Professor Wander sir said, India is turning out to be the center of diabetes in the world. And Indians have a very peculiar type of dyslipidemia. It is a highly atherogenic dyslipidemia. Why? We have a particular type of LDL which is called small dense LDL, which is highly atherogenic. And this is directly related to non-alcoholic fatty liver disease. Not only that, we have a peculiar pattern of abdominal obesity. Our BMI is normal, but still we have obesity because it is more of a visceral fat. And you know, this all causes insulin resistance. And insulin resistance is the hallmark for non-alcoholic fatty liver disease. If we have to define this disease, there are 3 essential components in the definition. 1, there has to be more than 5% hepatocytes have to be undergoing steatosis. So if more than 5% hepatocytes are into steatosis, this is one criteria. Second, the person has to have any of the metabolic risk factors. And what are these risk factors? We'll be discussing very shortly. And the last component is that there has to be an absence of disproportionate alcohol intake or any other further persistent liver disease. So if our patient fulfills all these 3 criteria, we can very safely suspect non-alcoholic fatty liver disease and proceed further. And let me tell you, in hepatology, this is a diagnosis of exclusion. You have to exclude other diseases before we come to the diagnosis of NAFLD. If we talk of the global incidence, I told you just now it's around 25%, and in India, it ranges from 9 to 10% to 55%. So 10 to 55% of our population is having this disease. And remember, this presents around 4th through 6th decade of life. And if you look at NAFLD, it has 2 essential components. One is diabetes and second is insulin resistance. And 60 to 80% of patients of NAFLD, they have insulin resistance, and around 20 to 30% patients of NAFLD have diabetes. So that means, in short, diabetes and obesity and insulin resistance, they are the hallmark of this disease. And both in the developing and developed countries. Now this disease is progressively increasing for a single reason, because we are into a global obesity epidemic. This graph just shows overall prevalence in the world. Almost it's around 25% everywhere in every country. Now these are the various comorbidities which are directly associated with NAFLD. May it be cardiovascular disease, may it be any malignancy, may it be diabetes and obesity, all these. So it's a multitude of diseases which are contributing to NAFLD. This is to show you that this is a dynamic disease, right? So it starts from simple steatosis. Steatosis means nothing but deposition of fat. The next stage is steatohepatitis. Steatohepatitis is when there is inflammation, there is ballooning degeneration. In the coming slide, I'll show you how the pathologist looks at it. And the next stage after steatohepatitis is fibrosis or cirrhosis. And it does not end there. Cirrhosis can further go into hepatocellular carcinoma. So this is a dynamic disease process. And this is how the pathologist looks at this disease. So if it is a simple steatosis, the pathologist will look at the slide like this. Unable to, otherwise I would have shown you the marker laser, but anyways. So at the top we have simple steatosis. Simple steatosis is non-alcoholic fatty liver. The next stage is hepatocyte ballooning and lobular inflammation. This is non-alcoholic steatohepatitis. And next is fibrosis. And as the fibrosis increases, this goes on to a florid cirrhosis. And so what is NASH? NASH is nothing but NAFLD plus ballooning degeneration and lobular inflammation. So if we combine the fat with this inflammation and hyaline or this ballooning degeneration or hyaline degeneration, it becomes steatohepatitis. And 5 to 20% of these patients, they would ultimately of NAFLD will go into NASH, and 10 to 20% patients of NASH would ultimately go into high-grade fibrosis, and less than 5% of these would go into a stage of cirrhosis. And out of these patients of cirrhosis, this flow chart shows us that 31% patients of cirrhosis over 8 years, they would go into a decompensated disease. And you know, decompensated cirrhosis is a very bad disease. And 7% of these patients of cirrhosis over a period of 6 to 7 years would develop hepatocellular carcinoma. This is just a slide to show you a direct head-on comparison of alcoholic liver disease vis-a-vis non-alcoholic liver disease. In addition to the other differences, one main difference which I would like to point out here is that the rate of progression, rate of progression from steatohepatitis to fibrosis or cirrhosis is much higher in alcoholics as compared to non-alcoholic fatty liver disease, right? So it is around 3 to 12% per year in alcoholic liver disease, whereas it is just 1.5 to 3.5% in non-alcoholic fatty liver disease. So this is one big difference, but otherwise this is it's not less bad than alcoholic liver disease. Now, there has been a big change, a change in nomenclature of the disease. Now it's no longer NAFLD. NAFLD is now metabolic dysfunction associated fatty liver disease. Now it becomes MAFLD, and or you can call it metabolic dysfunction associated steatotic liver disease. So the word fatty liver and non-alcoholic has undergone a tremendous change, right? And similarly, non-alcoholic steatohepatitis now becomes metabolic dysfunction associated steatohepatitis. That NASH becomes MASH now. Why this change? Why are we changing names? It has a logic. The logic is that the initial name, NAFLD, it describes what the cause is not there. कि अल्कोहल कॉज नहीं है, लेकिन कॉज क्या है ये नहीं वो बता रहा. तो जो नया नाम है वो हमें ये भी बता रहा है कि नया cause kya hai. It is not that it's not only alcohol, right? The second is fatty liver is sort of a stigma. So it removes the stigma now. Now we are not labeling it fatty. And this new name, it covers the entire spectrum of all the diverse etiology this disease carries with it, right? And it not only that, it emphasizes the influence of the cardiometabolic risk factors which are directly associated with MAFLD. And I'll be showing you what are the various cardiometabolic risk factors. And it allows, this changed name allows for a straightforward explanation for the disease. Now this is the Delphi consensus statement which recently came up regarding the change of nomenclature. So this consensus has changed the name. Very recently the name has been changed. So in which patients should we suspect this disease? Very simple formula I'll give you. Any patient who is having steatosis. Steatosis कैसे पता लगता है? ये भी हम अभी discuss करेंगे. So any patient having steatosis, you have to see whether there is any cardiometabolic risk factor, yes or no. If there is no cardiometabolic risk factor, this patient we should not suspect having MASLD or NAFLD. So this goes to the right side then. Now, then we have, if there is a cardiometabolic risk factor, yes, then either your patient has a isolated solely NAFLD or FAMSLD, or maybe your patient has steatosis, your patient has a cardiometabolic risk factor and is taking significant alcohol also. So then it could be a combination of non-alcoholic and alcoholic fatty liver disease, what we call as MET-ALD, right? So basically what the crux of this flow chart is that any patient who is having fat deposition steatosis, we just have to focus whether cardiometabolic risk factor is there, yes or no. No, we will not suspect this disease. If it's there, yes, we will suspect and we will proceed further. Now, these are some of the cardiometabolic risk factors which are there. Very simple. It's like diabetes, impaired glucose tolerance, hypertension, dyslipidemia, obesity, a high BMI or a waist hip circumference, and dyslipidemia generally we mean by high triglycerides more than 150. We'll be discussing them in detail just now. So if the patient has any of these 4 or 5 cardiometabolic risk factors and there is steatosis, we will definitely suspect this disease. Now, if we look at the fatty liver disease or steatotic liver, so now we use the word steatotic liver disease. So hepatic steatosis can have this total spectrum. It can be NAFLD or now what is called MASLD, or it could be a combination of metabolic and alcoholic, or it could be only alcoholic liver disease, or it could be cryptogenic without any cause, or it could be other etiologies. Other etiologies, you know, they are huge in number. Viral, toxic, metabolic, drugs, you know. There's a good large list of drugs which cause liver injury. So this is the total spectrum of steatotic liver disease. And in addition to alcohol, non-alcoholic or the MASLD stands out. Now these are the various, if we look at the etiopathogenesis of the disease in short, right? Because whenever we read any chapter, this is for medical students, when it comes to pathogenesis, we sometimes start feeling bored. The pathogenesis phir aa gaya. So to simplify the etiopathogenesis of this disease, we have these various etiological factors. May it be comorbid illnesses, maybe diabetes, obesity, insulin resistance, hypertension, dyslipidemia, whatsoever. Some genetic factors, and genetic factors as far as NAFLD is concerned, they are single nucleotide polymorphisms. These are some of the genetic factors. And on the right side, we have the environmental factors. What is our dietary pattern, our exercise, alcohol intake, and so many other things. So a combination of these contributes to the disease NAFLD, and this is just a repetition that all these factors, how they contribute to MAFLD. Now, if we discuss the pathogenesis, we will divide the pathogenesis into two. One, what is the pathogenesis of simple steatosis? And then we will discuss what is the pathogenesis of steatohepatitis. पहले steatosis होगी, फिर hepatitis पे जाएगा. So what are the various pathogenic factors for steatosis? Number one is increased delivery of free fatty acids to the liver. Free fatty acids body में इतने ज़्यादा हो गए, they are increased delivered to liver, and this causes increase in insulin resistance. Second, there is increase in the pro-inflammatory cytokines like leptin. And on the contrary, there is a decrease in the anti-inflammatory, adiponectinic anti-inflammatory cytokine है, वो कम हो जाता है. That goes down, leptin goes up. Then our dietary fructose. We have so many diets which are rich in fructose. They cause lipogenesis through carbohydrate metabolism. And last but not the least, they are farnesoid receptors. They are involved in bile acid metabolism. And once these receptors they are increased, they decrease the steatosis. So we should have more number of farnesoid receptor activity. Right? So these are the 4 pathogenic mechanisms which contribute to steatosis. Now once we come to steatohepatitis, again we have 4 factors. Number 1, very simple. These free fatty acids which are high in liver, they are directly lipotoxic. Second, there is a pathway which is called Hag-Hog pathway, where this lipotoxicity causes portal inflammation and hepatocellular ballooning. Third is that there are some surgical procedures where there is intestinal bacterial overgrowth. This intestinal bacterial overgrowth is directly related to NASH. And last but not the least, again obesity and fructose consumption. If it is increased, there are release of endotoxins in our intestine. And these endotoxins, they further cause release of inflammatory cytokines. So it is a combination of these 4 plus 4 pathogenic mechanisms which causes steatosis, and steatosis causes steatohepatitis. So this slide shows you how there is a strong interplay and correlation between all these factors, all these comorbidities causing increased free fatty acids, which is exceeding the limit of the adipose tissue and causing increase in insulin resistance and causing this disease. And once we come to the management, which we'll be discussing shortly, in addition to managing the individual comorbidity, the best part of the management is, which is shown in the yellow arrows, that it's better if we treat the insulin resistance. If we focus on the fatty acids, I think that would be much better. And of course, we have to treat the individual comorbidities also. How to diagnose this disease? I told you, this is a disease by exclusion. So any patient having steatosis, if there is no significant alcohol consumption, although is little different for males and females, but now we have just got one universal value, that is more than 20 grams per day. Ideally it is more than 20 in females and 30 in males, but then anything more than 20 grams per day should not be there. And you have to rule out other diseases like autoimmune, viral hepatitis, metabolic factors, toxic factors. If they are all excluded and there is steatosis, we suspect NAFLD. But let's not expect too many clinical features. The patients' majority are asymptomatic, no symptom. At the most, there might be some fatigue, some malaise, or maybe some pain in the right upper quadrant. And there might be some hepatomegaly. Then how are they diagnosed? Most of these patients, they are diagnosed incidentally. There is an incidental deranged LFTs. Patient कोई और काम के लिए hospital आया, आपने उसके LFTs कराए, AST/ALT are deranged. There is an incidental hepatomegaly. And there is an incidental steatosis. आपने ultrasound किसी और काम के लिए कराया, radiologist ने लिख दिया fatty liver. So these are the incidental markers of clinical diagnosis. And once we have this, we go in for some anthropometric measurements. BMI, waist to height ratio, waist to hip ratio. And you will find that if your patient is having this disease, these anthropometric measurements would be deranged. How to take the help of laboratory? AST/ALT, they are raised. They are almost 2 to 4 times the upper limit of normal. But remember, AST to ALT ratio is less than 1. And you know what is the ratio in alcoholic liver disease? It is the reverse. In alcoholic liver disease, the AST to ALT ratio is more than 1.5. Right? So here it is less than 1. Alkaline phosphatase may be slightly raised. Remember, these three parameters are always normal. Bilirubin, albumin and PTI-INR. They would never be deranged. Yes, serum ferritin would be raised. And if serum ferritin is raised, take it for granted that this is an indication of advanced disease. Now, this is a very important test which is mentioned at the last. This is HOMA-IR. This is homeostasis model assessment for insulin resistance. आपको सिर्फ दो values चाहिए, insulin fasting and fasting glucose. You can calculate this by very simple formula. And if it is raised, take it for granted if you are suspecting NAFLD, your patient will be NAFLD, especially if this value is more than 2.5. And we have some clinical scoring systems, very simple to use. Out of all these scoring systems, three are very important. One is NAFLD fibrosis score, NFS, which has got 7 parameters. And if the value is less than 1 minus 1.455, this excludes advanced fibrosis. On the other hand, if this value is more than 0.676, it means your patient has entered the stage of fibrosis. Similarly, we have another score, FIB4. It is very frequently used by the clinicians. FIB4, it has 4 parameters. If the value is less than 1.3, this rules out advanced fibrosis, right? Similarly, we have a very commonly used score, APRI, which just has 2 parameters, right? So once we are treating these liver diseases patients, patients of hepatitis C and other patients, we are routinely calculating FIB and APRI to see whether this patient has fibrosis, yes or no, because the treatment modality changes. Then we have other scores like BARD, ELF score, but the commonly used scores are the top 3 ones. Now the biomarkers, very important. Now what is the importance of biomarkers in this disease? The importance is that they help us to differentiate simple statosis from statohepatitis. That is very important. And we have some of the biomarkers. More important is CK18, cytokeratin 18 and procalcitonin 2. Now, what is the problem with these biomarkers? The problem is they are not easily available, they are expensive, and they lack standardization. Right? They are quite costly. So every patient cannot afford it. So then we have to depend on the Department of Radiodiagnosis then. So we ask the patient to get an ultrasonography. Now, simple, cost-effective, non-invasive, easily available is ultrasound. And it carries a sensitivity of 90%. But when more than 30% hepatocytes, they have undergone statosis. Now that is a big condition. But now, recently we have some software which is coming up. It's already there. That software, if the machine is equipped with, then there is a very good quantitative assessment of fat by the ultrasonography. This is a recent software which is already in the market. The next is elastography. You must have heard. Elastography can be transient elastography or fibroscan, or it can be shear wave elastography, or this could be done by MRI machine. Then it is called MR elastography. What is the function of elastography? Is to measure the liver stiffness. ये हमें fibrosis बताती है कि liver में fibrosis कितना है, right? It's got a very good sensitivity and specificity. Next is CT scan, right? CT scan can detect the fat and the fibrosis, but it carries high amount of radiation, right? And of course the cost is there. MRI, very good investigation, sensitive, specific, but again expensive. MR elastography I just talked about. It's a very sensitive investigation, but again some cost is involved. The last is MR spectroscopy. Now, I'm going to focus on this. Why? Because MR spectroscopy is the most sensitive modality for detecting fibrosis in the liver. Most sensitive. The only problem is that it is definitely costly, but it has been seen, or the data says that this is very sensitive modality. Liver biopsy, gold standard. And once you do liver biopsy, you can stage the fibrosis. And you have 2 scoring systems, 2 or 3 scoring systems on biopsy also. Histologically भी आपके पास scoring system है. उसमें NFS था, इसमें NAS है. NAFLD activity score. So if it is more than 5, your patient has NASH. If it is less than 3, no NASH. Similarly, there's another SAF score is there, and if the value is more than 3, it indicates fibrosis. Now, there was a time, even when we were students, there was a time liver biopsy was done very frequently, because other modalities were not there. But now, since we have so many other modalities to image the liver, now liver biopsy is not a preferred choice. Why? Because it is invasive. It carries complications, right? And there is inter-observer variability. Not only that, आपने sample लेके भेज दिया, sampling variability भी है इसमें, right? So these are some of the demerits of liver biopsy. So liver biopsy is done now very selected cases, although it is the gold standard. Now, if we want to stratify this disease, right? You have a patient with fatty liver. You rule out all other causes. वही exclude आपने कर दिया. आपका diagnosis of NAFLD और MAFLD आपने सोच लिया. अब आगे क्या करोगे आप? आप उस पे 2 scores लगाओगे. अभी हमने discuss करे हैं FIB4 और NFS. ये 2 scores लगा दोगे. आपका काम बहुत आसान हो गया, right? If FIB4 is less than 1.3 and NFS is less than minus 1.455, take it for granted. Your patient does have only simple steatosis. उसको अभी hepatitis, steatohepatitis, fibrosis नहीं है. On the other hand, extreme right, if FIB4 is more than 3.25 and NFS is more than 0.676, take it for granted your patient has advanced fibrosis. And in this case, if the patient has advanced fibrosis, we have to further investigate the patient. Maybe you have to go in for elastography, biomarkers. Whereas if the risk is not there, then you just have to observe the patient. You have to treat the comorbidities. Now, these are the INASL. INASL is our association for the study of liver diseases, Indian society. And in 2022, they have given the clinical management guidelines for the treatment of NAFLD. Now here, again, 2 scores are used, but 1 score is same. FIB इसमें भी है, लेकिन इसमें NFS की जगह EPRI आ गया. EPRI तो और भी आसान है, right? So if FIB4 is less than 1, EPRI is less than 0.45, your patient has low risk of significant fibrosis. On the other hand, if the FIB is more than 1 and EPRI is more than 0.45, this patient needs care. This patient is a candidate for further elastography. And elastography, just for your knowledge sake, elastography we just discussed, it measures the liver stiffness. Liver should not be stiff. If the liver stiffness is increasing, that means your patient is going into an advanced stage of fibrosis. So if the liver stiffness measurement, LSM stands for liver stiffness measurement. If it is less than 8.2 kilopascals, okay. If it is 8.2 to 13.6, this is a patient who has got steatohepatitis. And if it is more than 13.6, this patient has cirrhosis, right? And this is how we follow these patients. Less than 8.2, just we'll keep a watch on the patient, treat the comorbidities, usko bolenge apna weight kam kar, lifestyle modifications le. 8.2 to 13.6, these are the patients who need attention. Why? Because abhi fibrosis nahi hua hai. These are the patients who should be targeted for treatment for pharmacotherapy, which we are going to discuss. Because if it exceeds 13.6, then the game is over. Then it is cirrhosis. Then the patient will have full features of liver cirrhosis, right? So if we have to see the guidelines for management, we'll group it into 3: lifestyle modifications, pharmacotherapy, and bariatric surgery. So we'll just spend a minute each on each one of them. So the first one is the individual. It has to be an individualized therapy. You have to advise exercise, diet program. The patient has to lose weight, and the patient has to quit smoking, alcohol, all these things. Fructose intake has to be decreased, and you have to target the diabetes, dyslipidemia, hypertension, obesity, all the comorbidities, right? Now this is lifestyle. I've tried to focus all the lifestyle measurements in one slide, right? So we start with calorie restriction, weight loss. Remember, one important point about weight loss, it should be a slow, gradual, sustained weight loss. वो ऐसा weight loss नहीं कि एकदम से खत्म down और एकदम से फिर वो ऊपर भी जाता है. That's not required for NAFLD, right? And generally 5 to 7 or 10% of the weight should be lost in 6 to 8 months. 6 months, that is ideal for NAFLD. And alcohol intake, I told you, should be cut down to less than 20 grams if at all it is there. And low fat diet and walk, yes. 45 minutes of daily walk, simple walk, maybe for 5 days a week is good enough. And even this is good enough for cardiac diseases. And it's good for all the metabolic diseases, right? Other things, you have to optimally control the sugars, optimally control the lipids, avoid alcohol, and a patient who has already developed cirrhosis, you have to use these vaccines. Vaccine for hepatitis A, for hepatitis B, for pneumococcus, because this is an immunocompromised patient now. And you have to use the important drugs so that HbA1c remains less than 6.5. Pioglitazone is used not only in diabetes, but it is used in non-diabetics also in NAFLD. We'll be coming shortly to that. Hypertension, Professor Wander talked in length just now. So target should be systolic less than 130, diastolic less than 80, and the preferred drugs are ACE inhibitors and ARBs. Dyslipidemia, yes. Statins are used except for if the patient has decompensated cirrhosis, then we try to avoid them. But otherwise, our target should be that triglycerides should be less than 150, LDL should be less than 100, right? Next is our specific pharmacotherapy. Now in this, the most important group is the insulin sensitizers. You know, insulin resistance is the main cause. So we'll focus on insulin sensitizers, and your metformin is a very good drug used in diabetes and so many other indications even when the patient is not diabetic. And this is one of the important indications. It improves the LFTs and insulin resistance, but it does not have any good effect on the histology though. And then we have pioglitazone, right? Thiazolidinediones, it is PPARA gamma agonist. You know, it is a wonderful drug which is being used to not only to control diabetes, but it has been seen that if it is used in the dose of 45 milligram per day for 6 months, or you can use it a lower dose, 30 milligram per day for 96 weeks. And there have been studies where pioglitazone has been directly compared with vitamin E. And there has been some outscore for pioglitazone, and these are some of the incretin mimetics, GLP-1. Two important drugs are there, liraglutide and semaglutide. They are weight-losing drugs. And DPP-4 inhibitors, you know, students know these are the oral hypoglycemic agents, but they are weight neutral, right? Other important product is vitamin E. It's very much in the market since long. It is an antioxidant, and when used in 800 international units per day in divided doses, it is good for steatosis and histology, right? But you have to take care. What care? You have to use in non-diabetic patients, and this carries a risk of carcinoma of the prostate and some risk of hemorrhagic stroke. So you have to be selective in choosing the patient for vitamin E, but generally it is used. A very good drug. There have been good trials with vitamin E with seroglitazar, vitamin E with pioglitazone, and vitamin E has a good efficacy and it can be used, but you have to be very selective. And then the lipid lowering drugs, you know, the most common are statins. And if the statins are unable to achieve the targets, you can add other drugs like ezetimibe or PCSK9 inhibitors. These are also add-on therapies. And now you know recently we have bempedoic acid, which is a very good lipid-lowering drug. These are some of the miscellaneous weight-losing drugs. ठीक है, ये मार्केट में चलती रहती हैं, orally stat पहले बड़ी यूज हुई, अब नहीं हो रही है. So some of the combinations, but this, yes, liraglutide is definitely going on these days. Now, these are three or four important drugs. Saroglitazar, which is a dual PPAR alpha and gamma agonist. It is 4 milligrams per day. I'll show you just 2 slides where this has been studied very nicely. Pentoxifylline is another drug which is used. And then we have obeticholic acid, which is pharmacoid X receptor agonist. I told you it helps in bile acid metabolism. Now, saroglitazar, a good drug, and I know I'm just so this study, saroglitazar versus vitamin E, right? The only thing is there was some saroglitazar outscored vitamin E little bit, but still it has the effect on fibrosis is debatable as far as saroglitazar is concerned. Bariatric surgery, yes. I'll tell you simple indication for bariatric surgery in this disease. If after 6 months of lifestyle modification, weight loss is not achieved, the patient should undergo bariatric surgery if the patient is BMI-wise is obese. And this helps in histology and the improved liver parameters. Last is the liver transplant. I just told you it has become the second leading cause for liver transplant and liver diseases and is still increasing. And remember, this is mainly recommended for advanced NAFLD, where the patient is going into hepatic failure, as other indications of hepatic failure are there. Now, this EASLD guidelines came out in 2022, which tell us that it has to be a multidisciplinary approach for the management of NAFLD. There's a lot of work going on, NAFLD, MAFLD, many molecules are in fray, but not documented as such. And the take-home message, my friends, number one, is that NAFLD is responsible for significant liver disease in our country. Number two, steatosis is a relatively benign condition, but remember, and NASH carries a significant morbidity and mortality. Number three, prolonged oxidative stress and inflammatory cytokine damage are the key pathogenic mechanisms. Number four, ultrasound and lab investigations, they remain the pillars for diagnosis, although we have other modalities, non-invasive, which are add-on modalities. Number fourth, sustained weight loss and lifestyle modifications are the mainstay of treatment. And in addition to that, insulin sensitizers, antioxidants, cytoprotectors, and hepatoprotective drugs, along with bariatric surgery, are the add-on therapies. Thank you so much.
Thank you, sir.